Okay, and then there are two last things, then we'll get to the official rebuttal. The one person, Daniel Carlett, said, oh, these are old studies, they don't count. And unfortunately, we don't have new studies, but we can throw out the old studies, and actually there are some new studies. And then here's my favorite post of all. It was related to Daniel Carlett. He says, it's a psychiatrist, he says, you know, we wouldn't have to be listening to this nonsense if we just had some studies that showed long-term outcomes. And I felt like posting, you're right, you wouldn't have to listen to this. All right, then I got invited to give a grand rounds at MGH, Massachusetts General Hospital. Now this, I believe, is the #1 ranked psychiatry department in the country. So this is not anything. And let me tell you how this invitation happened. Initially, I was invited out to a book group. It went well. It was nice. Some of those people had like psychotherapy sort of approaches. Next, I was asked to present to the schizophrenia group at MGH, led by Don Goff. So this is a very high-powered schizophrenia group, and it couldn't have been more respectful. Don Goff actually went back. I sent him the studies. He passed out those studies to the handful of people in there, and by the end of that, Don Goff was saying, wow, we really need to look at this, and we should be studying this. And by the way, you know what they told me about bipolar? They said, oh yeah, we used to just patch those people out and they'd go back out, you know, they'd have an episode, we'd patch them out and they'd be fine and maybe they'd come back 2-3 years. Now our bipolar patients are chronic. That's what they were saying. So they sort of admitted this change. So then I get this email from the head of the grand rounds. We think your book is important. Would you like to give a grand rounds? I said, sure, that's great. And I was so thrilled by this possibility. I said, we're making progress. They said, what would you like to talk about? And I said, well, why don't we'll just focus on antipsychotics and schizophrenia. The reason I like sometimes to focus on that is if anything we know to be true, when we say we, it's that antipsychotics are essential treatment for schizophrenia, right? That's the standard of care. You hit them with antipsychotics fast, it's considered you know, a violation from standard of care not to do that. And if you take people off, you have all sorts of vulnerability. So if any class of drugs, there should be a clear showing of improving long-term outcomes. It should be with the antipsychotics. So I said, I'll do antipsychotics. Okay, fine. Then I get this thing a little bit later saying that you only get a half hour, and now there will be a half hour for a rebuttal. I said, that's fine. And they said, please send your slides in like 2 months ahead of time. I said, great. And you send your slides in a month ahead of time, so I can see your slides. So I send my slides in, and their slides don't come back. They don't come back, they don't come back, they don't come back. I keep asking them, where are your slides? So we're getting them. Finally, 24 hours before, I get an email saying, here are the slides. But the slides weren't attached. So finally, about 8 hours before, 12 hours before, I got the slides, and I'm going to show you the slides. So what do the slides do? There's part one. By the way, so if you've ever been to the amphitheater, I got to move through this faster. If you've ever been through the amphitheater at MGH, it's this august place, okay? There's this big amphitheater. It's filled like with 300 people. The way I'm introduced is, we've invited Whitaker into the lion's den, and I say, yeah, and the question is, will I survive? But wait till you see what's going on. Okay, I think we're, by the way, I think we're having a debate on antipsychotics and schizophrenia. I get slides saying, no, we're talking about a refutation of my entire book. Okay? By the way, Dr. Nierenberg, go look at his disclosure statement. He works for about 15 different pharmaceutical companies. Okay, here's just his slides, okay? You can read it. He's going to show he's going to refute the book. He's going to repudiate the book. I guess if we didn't understand refute, now we can repudiate. Now I'm being compared to Sarah Palin. Just imagine the academic credibility Sarah Palin has at Grand Rounds. Everyone there appreciated it as well, I think, for a different reason. Okay, watch this one. Never assume malice when ignorance remains a possibility. They're setting me out as either being filled with malice or just plain ignorance. Okay, so here's the point. This is their opening thing. It's an ad hominem attack. And when I got the slides, I wrote back to Dr. Nierenberg. I said, I didn't really think it was going to be like this. He writes back, well, it's not an ad hominem attack. And I wanted to write back, well, go to your dictionary. Okay, now we're getting into the substance of it. What they're going to do here is they're going to say there is no rise in disability. It's not happening, okay? That's what they're going to claim here. That my claim that there's this increase in disability is false. By the way, the numbers I'm using are SSI and SSDI numbers, which is what people go on when they're declared, et cetera. That's the government support. Okay. Anyway, this is my data. It's just showing the rise. What I was talking about, and you'll see the rise. The most important is from 87 to 2007, because that's just the SSI and SSDI data. This is the numbers, 1.25 million to 4 million. So they're responding to this data, okay? And here he's just, I can skip through this, but he's basically saying the parts of the book is that there's a rising epidemic, that psychopharmacology is harmful, that I'm saying there's no biological basis for psychiatry, no evidence for chemical imbalance. One of the things I do in the book is look at the chemical imbalance story. Why don't I jump ahead to this part? That's what I was really looking at, is the story told to the public true? You know, that antidepressants fix low serotonin. I wasn't going into the whole biological stuff. Is that story true? And at one point, I should save this. No, this one's too good. I'm going to save it, all right? All right, so now he's setting out that he's going to show, okay, here's starting to be the substance of it. He says, listen, there's a stable prevalence of psychiatric disorders between 1990 and 2003. Okay, so there's no increase in psychiatric distress. Now, this slide is actually misrepresented. It's actually, this study is stable prevalence of affective disorders, but let's just let him have this, okay? Okay, this is the increased treatment of affective disorders. I think that's accurate, okay? So, his core point here is this. There's no increase of prevalence, but there's increased treatment. He's setting up. Therefore, if Whitaker's right, we should see an increase in disability. Okay, that's what he's setting up here. Okay, what happens is, in the book I say, listen, the hospitalized data, when we moved SSI and SSDI data, may be like comparing apples to oranges. So it's recognized, so I get this. Okay, so now he's saying he's going to present disability data. Watch this. That shows no rise in disability. So it seems like he's talking about psychiatric problems, right? Read this. Any other mental or emotional condition that seriously interfered with everyday activities. So he seems he's setting up, we're going to see disability data for psychiatric problems, right? Okay, now he's showing something that makes it look like there's been no change in disability rates between 1991 and 2002. Maybe all disabilities have gone down, right? So he's making the claim here that this appears to be disability data related to psychiatric conditions, and it's gone down, okay? This, I can't remember what that was for. Okay, so prevalence is stable despite increased rate of treatment, and he's saying that there's no increase in disability, okay? That's what he said there. Here's the key here. You know what this is? You know what this data is? I figured out when I had time to go back. This is a survey of people living with disabilities of all types. If you have Alzheimer's, if you have, you're paralyzed. And what he did is he picked out within that one paragraph of that larger disability thing that was related to, affective disorders. And he made it seem like that this report was only about psychiatric conditions. This is a Census Bureau report on the percentage of Americans living with a disability. Not on disability, not disabled by it, but that's what he's passing off as saying there's no decrease in disability to psychiatric conditions. So he is saying my SSI and SSDI data, which is hard data, is nonsense, and here's what he's passing off. Now my problem is I did not have time to, well, by the way, I was told I would not be allowed to respond again to their presentation. Okay, so you can see there's a dishonesty here, but here's the great thing is, this proves the point. Watch this. If prevalence doesn't change, but treatment does, and treatment increases the risk of disability, let's look at the real disability data. Okay, so I've talked about, how it's misaccurate, but watch this. So you go to the prevalence in 1990, the number of people with psychiatric disorders. Now, you have to exclude psychoses because actually the data is just for affective disorders. But let's just follow his reasoning. You look at the population, that means 57.1 million people with a disability. 66 million in 2003 because the population's grown. You do the percentage of those treated, 11 million were treated in 1990, 21 million treated in 2003. Now you look at the number of people with a psychiatric disorder on SSI or SSDI. You see what's happened? There's a doubling during this time of increased treatment. Prevalence hasn't increased, but treatment has. Now let's go to the bottom line, the percentage of people with a psychiatric disorder on disability. In 1990, when there was less treatment, 2.57%. 2003, it was near 5%. So the very data they're trying to say disproves the book. When you properly parse it, it shows that prevalence is the same. So the amount of psychiatric distress in our society is not seen as increasing between 1990 and 2003. The only thing that has changed is more people are getting treated with drugs. And as that happens, the percentage of people on disability doubles. Okay, so that's part one. But obviously, I'm not allowed to present this. Okay, next let's go to antipsychotics and schizophrenia. And if those of you read the book, I go through this long bit of data about, there's 50 years of data. One of the things we have to understand about do no harm, what it means. Hippocrates was saying there is a natural capacity to recover from people, from many diseases, and to do no harm, your intervention has to improve on that natural recovery rate. So if you have a form of care that helps 25 to 40% of people, let's say 40% of people, naturally, let's say your form of care helps 40% of people. You got to know what is the natural recovery rate before you can assess whether that's doing harm. And if the natural recovery rate is 60%, you've actually lowered the recovery rate. Anyway, that's sort of the baseline for figuring out long-term outcomes. So real quickly, one of the key studies in anatomy of an epidemic is a long-term study done by Martin Harrow at the University of Illinois, okay? It's the only study that we have that follows people prospectively from the moment they're diagnosed for 15 years, okay? And the way the study works is this. There's 200 people initially into the study. Half are from a private hospital, half from a public. That way there's some class, diversity. Everybody treated conventionally with medications, okay? And then he's just going to follow them out of the hospital. They're discharged. And at 2 years, he's going to look, how are they doing? Are they working? Are they symptomatic? Have they been hospitalized? And are they using meds? Now look at the purpose. This is the first line of this NIMH-funded study. What is the purpose? It's to study whether unmedicated patients with schizophrenia can function as well as schizophrenia patients on antipsychotic medications. So the purpose, finally, is to look at what happens long-term to people that go off, all right? Funded by the NIMH, and he's had like 100 and you'll see, by the way, the reason that's 64 and 81, he keeps 145 in the study for 15 years. Any of you who do research, you start with 200, you end with 145, that's fantastic. Okay. Here's the actual data. This is my slides, okay? This is his data. Recovery rate, you'll see, off antipsychotics at 15 years, it's 40% for off, 5% for those on. That's an 8-fold higher recovery rate for those off, okay? And recovery, by the way, you had to be asymptomatic and working or in school half-time. So this is a pretty good recovery definition, and you couldn't have been hospitalized in the past past year, excuse me. This is global adjustment of all the patients. And by the way, of the schizophrenia patients, 25, I think, ended up off antipsychotics and 20 off any psychiatric medication. Okay, you'll see global outcomes much better for the off-medication group. By the way, these are big statistically significant differences. If you look at the spectrum of outcomes, it goes like this. On antipsychotics, 5% recovered, 46% so-so, 49% uniformly poor. That's the on-med group. The off, 40% recovered, 46% so-so, 16% uniformly poor. It's not just a lower recovery rate. You can see there's a shift among the medicated group towards worse outcomes. Which group was more psychotic at 10 and 15-year follow-ups? Those on medications, more than a 2-fold higher evidence. Global adjustment of the, he had a schizophrenia group and those with milder disorders. It's really an old manic depressive group. It's mania with psychotic features, depression with psychotic features. What do we have from global outcomes? The off antipsychotic group, much, much better. By the way, just so you know, but more than half got off in this group. And you look at this off antipsychotic group, the scale of 1 to 8. 1 to 2 meant recovered. You know what the aggregate score was for those off medication long term? It was like 2.13. It was really good for the off medication group, okay? Now, this is a graph I think psychiatry really needs to deal with. This is he ends up with 4 groups. Milder disorders off, milder disorders on, schizophrenia off, schizophrenia on, right? Remember, schizophrenia by diagnosis means it's more severe, right? Look how it racks up. Milder disorders off meds is the best. Schizophrenia off meds is second best. Then milder disorders on meds. Schizophrenia on meds is the worst. You see the real problem with this data for mainstream psychiatry? Is you got the milder people on meds doing worse than schizophrenia off. Martin Harrell also has a thing where he has good prognostic schizophrenia patients, bad prognostic schizophrenia patients. Maybe we'll talk about how we will in just a second, how he discusses it. But the bad prognostic off did better than the bad prognostic on. The good prognostic off did better than the good prognostic, the good prognostic off did better than the good prognostic on. So the point of this study is every subset you can find, long term, the off medication group did statistically better. Okay, so what's going to happen now at MGH? Oh, here's his conclusion, okay? I conclude that patients with schizophrenia not on antipsychotic medication for a long period of time have significantly better global functioning than those on antipsychotics. This is a remember what the study was designed to do? This is the conclusion. This is done by the NIMH. This is a real threat to our understanding. So, at MGH, they're going to have to attack this. Oh, by the way, we'll get back to this. Let me come back to that later. Okay, he's just going like, amazingly here, he says, assertion partially true that maybe the drugs are harmful for some. That was rather amazing. This is a misquote. It doesn't really matter. Then he says, he says, I'm not up to date. I'm somewhere back in the 1600s with my understanding of mental illness. It's just so stupid, you know what I mean? But that was the point. I'm not quite up to 1600s. That's how far behind I am in the Dark Ages. This is all, this stuff, like, all this rigmarole. Okay, now the Harrow study. Now watch what he does. First of all, he says there's no randomization, and he says it's a retrospective analysis. What was the opening line? Prospective. What's the difference? Prospective are much stronger studies because you're starting with everybody from the start, okay? So and you can't miss this. This is the opening line in the PACE is prospective study. But he's going to have to attack the study. So he calls it a retrospective study. Next thing he knows, he pretends the numbers are less. He says 77% dropout. He says, oh, there's only 50 left. Well, they start with 200. 77% of 200 is 145, and et cetera, and you divide it into 2. So he's doing that, okay. And then, blah, blah, blah. Okay, then he says this. The explanation is, this study is just a matter of people with good prognosis going off the meds, okay? Now, there is a problem here. When Martin Harrell came up with this data, he was told by psychiatry, do not publish this data, okay? And the reason I know this is I interviewed him, and the interview went like this. He gave his talk, and then he said, well, the explanation goes like this. I said, what happened? The explanation is it was good prognosis patients who got off, and everyone benefited from drugs. The good prognosis patients stabilized on the drugs, and that enabled them to go off. So really what you're saying is that there's just a subset of patients, they benefit short term, and then they can go off. And then I said to Dr. Harrell, I said, but that's not what your data shows. And I basically summarized this data, and he got furious with me. And then goes off the record, he says, do you understand, I was told not to publish this data. And by the way, it was not published in an American journal. It was published in a British journal. Okay? He was told, and he said, I'm worried about my continued funding. And he says, you can say that maybe the problem is an iatrogenic problem, but I'm not going to say that. And the message was, you can't say that within the academic environment. So what what Dr. Nierenberg is, he's going to hold me to task for that. This is just a matter of good prognosis patients going off. So that's what he says. Self-selected, that's true. Better early prognostic features, not true. Every subset, it didn't matter. More favorable personality characteristics? Well, what happens is, in the good prognostic group, it was those who had a better inner sense of self that went off. So actually, is that better prognosis, or is that sort of a better togetherness in terms of response? Et cetera, better developmental potential, better developmental achievements, more likely to insist on. So they're just saying this is a self-selection thing. Okay, group without meds at 15 years had better prognosis at baseline. What do we see with the milder disorders versus schizophrenia? This is not true, right? The milder people have a worse prognosis than schizophrenia. Reverses cause and effect, fails to acknowledge, blah, blah, blah. I just want to point one thing out here. He's misrepresenting the study, but on the other hand, I, as a reporter, was in a jam. And this happens a lot. I knew what the data said. I built those charts. The one that had all forth, I built it from a table. I went into the data when he has one paragraph on the good prognosis and the bad prognosis. But he spins his data. He says it's just a matter of good prognosis going off. So when I reported in the book, I gave his explanation, and I said, but maybe there's this other explanation. But the problem is, my responsibility to my reader, do I just say this is a matter of good prognosis patients going off? I don't do that because that's not what the data shows. But it left me vulnerable because I was at odds with the discussion of the researcher himself. And I should have spent more time on this. But that's what they're attacking me for here. In essence, they're saying I didn't follow Harrow's discussion. Okay, now look at this. I'm going to have to wrap this up because I'm going a little long. This is the one moment that psychiatry says, here's our evidence that you need to take antipsychotics for life. This is coming from the #1 psychiatric department in the country, okay? So what does a study seemingly show? Lloyd? The green one is no treatment, okay? So and that one shows a lower percentage in complete remission, supposedly at the end of 2 years. A lower percentage in partial remission. A higher percentage still schizophrenic, and the small group deteriorated. Okay? So they're presenting this data as showing that untreated group in this rural population in China, those who did not get treatment at the end of 2 years, were doing much worse. And this was the evidence that countered this long history of evidence I put together in the book of NIMH evidence. This is what they're pointing to as their evidence base. Now, what is this study? You want to know what this study really is? Here's the study. I didn't have time to do it because I only had this 8 hours. I had to go get the study. Researchers go into this Chinese community. And they ask around. They say, who are your crazy people? Seriously. And they identify 510 crazy people. Now, of the crazy people, 156, still crazy, had never been treated with antipsychotic medications. And that group was about 47 years old at that time and had been ill for around 13 years, okay? By the way, imagine you were crazy 13 years earlier and you stopped being crazy without treatment. You're not going to show up, right? This is the people who stayed crazy. Now, the group that has got regular treatment with antipsychotics is much younger. They're like in their 30s, and it's an N of 30. That's their N. And they had been ill on average 5 years, okay? But here's the great thing is, this is not a 2-year outcome study. You know what the study is? They now just follow, that's the baseline data. That's not the 2-year outcome data. That's what they saw when they came in, is that 30% of the people with regular treatment within remission, etc. That is the baseline data. This study only follows the no treatment group. It's not a 2-year study that compares outcomes. And they follow the people who didn't get treated, that N of 30, at least my understanding of it. It's a very confusing study. And guess what? The 30 stayed crazy. They've been crazy for 30 years, and they stayed crazy. And that's their evidence why you got to use antipsychotics. But there's a kicker to even this. That was their clinical symptoms. They were still crazy. You know what their employment rate was? The never treated group? 80% or something. 77, 80%. So they concluded that being crazy didn't inhibit your capacity to work. And that is the one study that has been presented by the #1 psychiatric department in the country, saying that we have evidence that medications improve long-term outcomes. I'm not kidding you here. This was it. Okay, real quickly. Then they attacked the Finnish study. That's the one in Western Lapland where they use antipsychotics in a very different way. Where they use it in Western Lapland, they do not put their first episode psychotic patients on antipsychotics right away. They try to delay it. They've been doing this now since 1992. And the way they use antipsychotics, if someone's not getting better after a period of time, they will put them on. They'll use low doses. They'll keep them on for a short period of time, and then they'll try to taper them off. Long-term antipsychotic use goes like this. At the end of 5 years, 67% of the patients have never been exposed to antipsychotics. 13% a short period of time, only 20% on the drugs long-term. Here's their long-term outcome data. 80% are working or back in school at the end of 5 years. The unemployment rate for that 80%, and they're asymptomatic as well, is lower than the Finnish population as a whole. So this selective medication use is by far the best outcomes in the rest of the world, but they have to attack this, and basically it just makes no sense. You see the no propensity analysis for outcomes? They're pretending that this was a study that compared medicated to unmedicated patients. That's not what Western Lapland is reporting. They're just reporting their outcomes for everybody. It's not even a medication for no medication study. Okay, I got to go. So you can see how they defended antipsychotics. They falsely stated it's a retrospective. They misrepresent numbers in the study. They ignore profound differences in outcomes for every patient subset, and they accuse me of ignorant, etc. All right, they misrepresent. I'm going to skip antidepressants. Basically, it's the same thing, okay? They misrepresent some data. The data they showed, real quickly. You know what the data they show that you have to keep people on antidepressants long-term, and they pretend it's a 25-year study? Within a long-term 25-year study, the psychobiology of depression research study, they had many smaller studies. And one of the studies was if you relapse, either while on drug or after drug, what is the dosage that helps you get better again after relapsing? It was a dosing study. And what they found is in this study, if you use high doses, you do better afterwards than if you use low doses. In this study, there's not even a no treatment group. Okay? I don't even know where they get the compared to no treatment, because everyone was put back on drugs. And it was not a 25-year, it was presented as 25 years naturalistic follow-up, but this subset was for a dosing study. And you want to know what the actual, sorry, and I'm going to stop. Here's the actual study that compared untreated to treated within that same larger study. And what happened? Of those treated, 3 times as much cessation of role function. Okay, 2 minutes. Oh, 5 minutes. Okay. And 7 times higher for the treated group to become incapacitated. That's the same study. And this is a 6-year study. This is 6-year outcomes. And this was the one NIMH study to study long-term outcomes in modern times, disability rates between treated and untreated patients. That's the actual study, and instead they replace it with a dosing study after you've relapsed and how quickly you do it. Okay, my point of this is, the point of this study is, this was when mainstream psychiatry said, we will show you the evidence that counters Whitaker, and they had to lie. They had to misrepresent data. That's the key thing. And just so you see, they weren't done. Oh, by the way, Gerald Rosenbaum was the head of the department, and he is named, and he's sitting closer than you are to me during this. He's named in the last part of the book as one of the people who basically, under the influence of money, lied to the public about the suicide risk on Prozac. So he's not real happy with me. Anyway, so they're challenging me this. Now they're saying I'm not solving everything. What's astonishing about it? Blah, blah, blah. But this is my favorite thing. This is the final slide. Can you read this? Warning. It's a black, he says, this book needs a black box warning. This book contains misinformation, simplistic misinterpretations of statistics, faulty reasoning, and wrong conclusions that may lead to harmful outcomes if it convinces readers who have psychiatric disorders to stop taking medications. Now, when he read this, I swear to God, the psychiatrist next to me went, yeah, black box warning. Last thing here. So then this led to a debate on the local radio station, and here's how when they put up the talk of the debate, here's what they wrote. 2-minute warning. Lloyd's going to have a hook, and I'm going to be bold in 2 minutes. The claims made by Robert Whitaker, I'm just like some nobody. Oh, that should be local journalist and author, that's right, are refuted by reputable members of the psychiatric community here in Boston. You see what they did here? They said, this is over, folks. And last thing is, this was not an accident. The next day, so this happens, MGH says they repudiated anatomy of an epidemic. I started getting now cancellations for talks, especially by those that were using some county money to fly me out. You know, there would be a misuse of money to bring me out because Bob Whitaker's book has been repudiated by what is it called? Refudiated, right? By reputable members of the psychiatric community. And then one of my next talks, someone stood up and said, why are we listening to this guy? This was from NAMI. He's been repudiated. It was like a talking point that was then being sent around. All right, I'm going to get going. Last little bit of thing. Friday I was speaking, what day is today? Saturday? Yesterday morning, I believe it or not, I was speaking before the American Psychiatric Association at a meeting in San Francisco, the Institute of Community Psychiatry. And the place was packed. In fact, there was like 250 people who couldn't get in the room. And actually, it went okay. You know, I was introduced to, the funny thing about this is about 2 months ago, the APA sort of put out an official statement sort of condemning me. And now here I am talking. And anyway, but my favorite moment was this. At the end, the person who was just past president of the APA came up and said, you know, you're causing us a lot of trouble. She says, even my own family members want to come off the drugs now.